Hello, everyone. I'm Soulmate Tibabu, your host of the Expanding Access podcast, and I'm so excited for this amazing conversation with two wildly impressive brothers today. Thank you both for joining us. Before we get started, perhaps I can have each of you just introduce yourself briefly, name, title, company, what you do. Let me see. Who do I pick first? Let's go. Arpan.
Thanks, Soulmate. It's a pleasure to be here. Thanks for having us. So I'm Arpan Parikh. Nice to be here and great to be in front of the audience. I am a psychiatrist by training, born and raised in the Midwest, and I'm sure you'll hear a bit more about our origin story in a little bit here. But today I'm the Chief Medical Officer at Soul Mental Health, which is an integrated care, multi-specialty outpatient behavioral health platform that operates clinics across the country. I live in Los Angeles with my wife and an almost 2-year-old daughter and 5-year-old golden doodle puppy.
Oh, fabulous.
And hey, everybody, my name is Amit Parikh. I'm also a psychiatrist by training, but also specialize in child and adolescent psychiatry. I, of course, grew up in the Midwest with Arpan and have kind of lived between Ohio, then Los Angeles, then I was in New York, and now I'm back in Los Angeles. So now we're neighbors again here in LA. I am the Chief Medical Officer at a company called Brave Health. And we are a fully virtual outpatient mental health company providing therapy and psychiatry services built for Medicaid populations. And so we typically serve rural and underserved communities.
Mm-hmm. It's amazing. Now, I have to ask, who is older?
I'm older, but Amit is taller. So people get that confused a lot and when they meet us in person.
So great. Yeah. Well, you'll be first in my questioning then, Arpan. Tell me, how did you guys get into this field?
It's a great question. So psychiatry has become the Parikh family business. Both Amit and I are psychiatrists. Our youngest brother, Ankur, became an ophthalmologist, so he strayed from the path, but he then married a psychiatrist, so he couldn't get too far away from it. And then Amit's sister-in-law is also a psychiatrist. So it's become kind of the most common profession in our immediate family. And I think there's no doubt that part of the reason why is our dad is a psychiatrist. So even though, me and Amit are here on the podcast and have had some success in our professional careers, I think we owe a good deal of that to the footwork and the footpath that he laid as a first-generation immigrant to America. With a really interesting story of how that unfolded and ultimately it matched into a psychiatry residency program in Cleveland, Ohio, which is how we ended up, being Buckeyes and Midwesterners. So I think for me, seeing the work he did and the joy and satisfaction that he brought home every single day, right, as a little kid and as an adolescent is certainly meaningful and had an impact on the way I thought about my professional career. And it's probably not a coincidence that the path converged on that over time.
I'm just thinking, go ahead.
And I mean, similar for me too. I knew I wanted to be a doctor. I didn't know what I wanted to do, but I think, when I was younger, I would always say I'm going to do something that's not psychiatry because I want it to be different. And lo and behold, here I am as a psychiatrist. And it's just funny how kind of life leads you down the path, and it was the best decision to choose this field, and I absolutely love it. But when you're younger, you want to be a rebellious person sometimes, but sometimes you can't escape that fate.
Well, speaking of which, Amit, if you weren't going to be a psychiatrist, what was the runner-up?
Yeah, so I thought I was going to be an orthopedic surgeon, actually, throughout medical school, almost all the way through medical school until I spent about 4 or 6 weeks doing surgery in the operating room. And I realized that I would rather spend time in the outpatient clinic than in the OR. And if you know surgeons, that's something no surgeon will ever say. They prefer to be in the operating room. And so I quickly realized that, okay, surgery isn't for me. And then it was really easy to fall back into psychiatry. And I think it's interesting because I think even though they seem so different, the one part that makes them similar to me is that it's a skill that you have to learn over time. It's not something you can read about, right? Like you can read about a surgery as much as you want, or you can read about how to talk with a patient to elicit a diagnosis as much as you want. But unless you practice and do that skill over and over and over again, you can't actually do it. And I think there's something about that component of it that really excites me about like learning a skill like that.
Fabulous. And Arpan, how about you? What was your runner-up?
Kind of a similar story. I went through medical school with a really open mind, not kind of narrowing in on anything until my third year, which is when, you do clinical rotations and get to actually experience the specialties. After my pediatrics rotation, I was 95% convinced that was what I wanted to do. I loved taking care of kids. And in that setting, I thought the pathology was really, really interesting. And I just had an amazing experience on my rotation, which was at Nationwide Children's Hospital in Columbus. But the next rotation that I had third year was psychiatry. And as much as I love pediatrics, I loved my psychiatry rotation even more. The fact that I could sit there, spend an hour with a patient, actually understand their life, and have the time and space to talk about whatever was important to them, and then develop this long-standing relationship with them was just really special to me. And like Amit, by far the right decision and one of the best decisions I've ever made.
Wonderful. And neither of you had said like rock drummer, like you're still in the wildly impressive range, but so great for both of you pursuing psychiatry, so important and needed, as you know. Now, if you could share a little bit more about like the day-to-day, maybe Amit, I'll start with you. Like, what does a CMO of Brave do? What's top of mind for you and your objectives in your role?
Yeah, it's so interesting because if you ask like two CMOs what their job is, they'll tell you two different things, and you kind of fall into different kind of like categories of types of chief medical officers out there. And so what I spend my day-to-day doing is kind of a mix of a few things. One is, of course, watching for our quality outcomes and safety of our patients and making sure that the care we're delivering is high quality and evidence-based. And so that includes making sure our team is doing well, that our clinicians are supported in the way they need to be supported, and that we have the right safety structures in place, especially as a fully virtual organization, to make sure the patients that we see are staying safe. And so that's one part. Another part is working with our payer partners, right? And working with organizations in the community, whether it's hospital systems or freestanding, PCP groups, et cetera, to forge and develop relationships in the communities that we're serving. And so we spend a lot of time working with our payer partners to prove out why we deserve to be in network and why we deserve to get paid for the services that we're providing, because we make such an outsized impact on the patients we serve. Not only their behavioral health, but their entire whole body health gets better because they're taking care of themselves from a behavioral health standpoint. And I think that's the drumbeat that I keep kind of pushing with our partners, is keep proving that point out of why it's important to make sure patients have access to this type of care, and working with the community partners in the same way so that they know that we're there to help serve the patients that they're seeing. And then the last part, I would say, is working with our teams to make sure the care flows are working for our patients and our clinicians. So it's making sure that as patients go through their journey of being a patient of Brave, that they are getting the right touch points and that it's a seamless experience so that it's easy for them, but also as easy as we can make it for our clinicians, so that their job is as easy as possible. And so those are like the three big domains, I would say, I spend my days and time.
Super interesting. How about you, Arpan?
Yeah, I think folks won't be surprised to hear that my answer is relatively similar to Amit's, given we probably have gravitated towards, similar businesses and enjoy doing similar things. I would break down what I do very similarly to how Amit did into 4 categories that really mimic the 4 core objectives that we've sort of anchored on at Soul. So the first is called integrated care excellence, which to me is that clinical excellence and making sure we're delivering very high quality care and making sure the teams have the backup and support to enable that and to do that, day to day, session to session. The second is focus on seamless experience. So that's making sure we have the right tooling and workflows, as Amit mentioned, for patients to have very smooth journeys throughout their care from the moment they raise their hand and say, I think I want to see a therapist or a psychiatric clinician, to the moment that they achieve their goals. And then we talk about what comes next. Third is focusing on superior access, which Amit also touched on. And this is something I really enjoy. So I spend quite a bit of my day and my week working on those strategic relationships and partnerships to make sure we are the mental health partner of choice in the communities that we serve, and that those partners know we're there to support their patients and their doctors. And then finally, and this is probably the most critical one, is making sure we are the best place to work for mental health clinicians. We all know that the existential crisis that faces services, businesses, and mental health today is our ability to attract and retain the best clinicians. So we have a lot of emphasis and teams spending their time on, and myself included, on making sure that we are by far the best place for clinicians to work. The only thing I would add, and this is also true for Amit, is we've both made sure that patient-facing time has remained a part of what we do. So we both actively continue to see patients in various settings. And I personally have a belief that in order to be an effective and excellent clinical leader, we have to stay close to the patients, because ultimately that's who we're here to serve. And it gives us a level of insight and also credibility with our teams when we are on the front line, so to speak, taking care of patients as well.
That's just so wonderful. And Arpan, if I could follow up on that, you talked about Soul Mental Health offers modern, hybrid, in fact, brick and mortar and virtual care for therapy. You mentioned integrated care, psychiatry, and more. There are so many clinical practice models today. Could you share a little more with our audience why this specific approach is best for patients and retaining clinicians alike?
It's a great question. So something I've written about and Amit has written about as well is in today's behavioral health ecosystem, we believe there's too much fragmentation. And that makes it really difficult for both patients who are seeking care, as well as players in the clinical ecosystem who are trying to direct their patients to the right place of care. And also for the folks who are paying for healthcare, whether they're payers or employers, to make sure their employees or members have access to the right care. So our approach at Soul has been build the most comprehensive clinical model possible that really hits the core components of what Americans today are looking for, and try to do it in such a way that folks can access most of the care that they need in one place. And even though that doesn't sound that groundbreaking, and it's really not, it's not as easy to execute on as I thought or as one could imagine. So it's taken us some time to really dial in the playbook. But today, offering both therapy and psychiatry together. And we know in the data today that when Americans see a therapist and psychiatrist who don't work in the same place, like less than 20% of the time are they actually coordinating care. And that's really bad for care, right? So number one, do it in the same place and encourage and motivate folks to collaborate internally. Number two, have a brick and mortar presence. Today, we see more than half and up to 3/4 of our patients want to see their clinician in person for that first appointment. So folks coming to us want that, because we're serving patients in major metro areas who are covered by commercial insurance and have the resources to come see us in person. So we're there for them when they need that. We are partners with their commercial health insurance. And so that means we're affordable. And we also partner with their healthcare ecosystem. So we're coordinating with their primary care doc, with their endocrinologist, with their rheumatologist to make sure everyone's on the same page. And then again, I'm going to keep hitting on this over the next 40 minutes or hour, being the best place to work. We have, best in class clinician retention, and that's not easy and it's not a fluke, right? A lot of effort has gone into that. But in our business, in Amit's business, continuity of care is key for outcomes. And if clinicians are turning over and we're constantly having to transfer patients from one to the next, it's a really bad experience. And it's also really challenging to maintain outcomes. So having a really high fidelity clinical employment model, which has a lot of pieces as part of it, has enabled us to deliver continuity of care, which then drives everything else that we're trying to achieve.
And I could see why, as you mentioned, payers are interested in this model and how you can deliver some great outcomes as a result. For the plans and providers in the audience, could you share a little bit about your experience? What have you learned in terms of successfully partnering with health plans?
Yeah, it's a really important question. I think it's one that doesn't get talked about enough, particularly in our world of behavioral health and mental health. So, when we started at Soul, step one was make sure we're in network with all the major commercial plans. It's not easy to be strategic with an insurance plan when one is a relatively young or small or early stage company. So it was really about get in network, right? Make the right relationships, but then the proof is in the pudding, right? So what has to happen then is actually delivering great care to the members. And that's what we've been able to do, and then continue to do it at scale as we went from 5 to 7 care centers when I joined Soul almost 4 years ago to now being, closer to 30 care centers. And now that we've built those relationships and we have the scale and the outcomes to show, it lets us go back to the drawing board with our payer partners and say, we've been really good partners. It's not just about us having a contract. Now we built that trust with you and we want to be collaborators with you. Here's the data. Let's be fully transparent on what we're doing with your members and what you want from your clinical, delivery partners. Tell us what your challenges are as a payer. We'll tell you what our challenges are as a care delivery org. And let's figure out how we can find something that works beneficially. To me, that has been where we've seen the most success with our payer partners. And I would say similarly with large employers, right, who to some degree are their own payers. Obviously, they use a payer network as their administrator, but really, that employer is on the hook for the cost of care and the claims for their employees. So it's about get in network and start showing outcomes, and then use that to forge a strong strategic relationship that then allows incentives to be fully aligned and deliver really good care for patients while also achieving the outcomes of the payer, which is to do it in the most, economically efficient way possible.
Yeah, it seems straightforward, but what I'm inferring is first build the relationship, the early outcomes, the trust, and then the cool and creative stuff comes after once that shared understanding is there and you get to know each other. I just feel like that's a bit important to call out given the startups in the audience who are have big plans but need to start small. So thank you for that.
That's right. It's about starting with the basics. And ultimately, we're here to take care of patients. Take really good care of patients, devote resources to doing that, and everything else will follow if that's going smoothly, which again, it's not easy or simple to do that. It takes a lot of effort and time and intention, but that is the key to success.
One thing I'll add that I think has become more and more important here too is understanding where the payers are coming from when they're having conversations to you, to understand kind of how they're thinking about things at a population health level, right? Because they have access to data that we don't, such as claims. So they're seeing the full cost of care for those members that are in their plan. And so it's understanding how you tell the story of the services you're delivering and how that's also helping their members with outcomes, but also with overall costs, which is, of course, what the payers are thinking about a lot and from their lens. And so it's building your model to be able to prove that from the start. So you're gathering the right data points to then share with them to prove that impact is really important. So it's just kind of learning the things that are top of mind for them and then speaking their language.
Oh, that's great, Amit, because also in today's environment, a lot of these payers already have many other solutions that need to coexist. And if you can help paint that picture, they can also connect the dots on their end to make it the best experience for everybody. And now turning to you, Amit, a little more, I would love to hear your experience leading a CMO of Brave Health. Today, to my delight, we focused on providing culturally sensitive care to diverse audiences. I know Brave has been an early leader in that, especially in the Medicaid market. Can you talk a little bit about what does it successfully take to run an organization like Brave today?
Mm-hmm. And so I think it starts with understanding the patients that we're serving, right? And so here at Brave, we have a slightly different model than at Soul. We are a fully virtual model, and we get in network with every payer in the states that we're in. So that's Medicaid, Medicare, and commercial. And so as you can imagine, about 60% of our patients are Medicaid or are on Medicaid insurances. And what that means is that our patients have different challenges and struggles in their life that we really have to understand from a social determinants of health, and figuring out how do we meet them where they're at. They may have unstable housing. They may have food insecurity. They may not have access to safe places to live, right? And so it's understanding the whole person, understanding the context of the situation they're in, and then delivering the care in the best way possible, knowing that there may be constraints and bounds on the care we're delivering. And so if I, as a psychiatrist, know that my patient maybe doesn't have access to food consistently, I'm not going to prescribe them a medicine that you have to take with food, right? And so it's like thinking through how the treatments we're delivering need to be adjusted and modified so that we're setting them up for the best chance of success. And that's really where our virtual model comes into play, because a lot of times our patients don't have access to things like transportation to get to their visits. And we know that when patients miss visits, what happens? They're not doing the treatments they need, such as the therapy services. Maybe they're not getting the medications they need on the psychiatry side. That leads to worsening symptoms and crisis, and then engagement with higher levels of care like emergency departments and then inpatient psychiatric units, just because they couldn't get access to the care they need. And so that's why we kind of have developed this to make it as simple as possible from the patient perspective. And so on their end, it seems like there's no technology. In the back, there's a lot of data structure and technology that drives it all, but patients are communicating with us via text when they need things. When it's time for their visit, they get texted a link. There's no apps to download, no usernames or passwords to remember. We just know that we have to get rid of all of that friction so that our patients have the best chance to actually make it to their visit and complete those appointments. Because that's how we keep them engaged in their outpatient level of care, which is what a lot of our population needs. Because a lot of the population we serve does have severe mental illness, and so things that may need lifelong treatment.
And it sounds like, from what you're saying, to successfully serve patients that may have additional social determinant needs, as you mentioned, you really do have to be 5 steps ahead thinking of all of these things to support them. But it also would require some payer partners that are equally innovative and open. Is that fair to say?
Absolutely, right. It's working with them and figuring out how we understand the difficulties they're having, and we tell them, hey, this is the difficulties we're having, and we come together to figure out, okay, we are both seeing this. How do we attack this together? Let's create a model here that's really going to work. And one of the things that we hear a lot has been, it's really hard to find patients who are discharging from higher levels of care their appointments, right? Because we know that window right after an inpatient psychiatric admission is probably the most critical window from a safety standpoint. And so it's working with them when we developed a service so that we can get guaranteed appointments within 7 days of those discharges. And so it's creating transitions of care services or other services that really meet the needs of those patients, and making sure that they're getting quick access, especially for the higher risk population.
Oh, and embedded in your response there too was including the folks that you're serving in the design of the services, which is just so critically important, and definitely something we talk a lot about here at Behavioral Health Tech. And now, maybe stepping back a little more broadly, I'd love to ask each of you if you have a view on how just the business and practice of psychiatry needs to evolve, especially in this day and age of AI and technology. Maybe, Arpan, I can start with you this time.
Absolutely. It's a really interesting question, but a really important one. We're at an inflection point as a specialty when it comes to the way we both practice using the technology that is becoming very routine and standard, and also the way we integrate into the larger health system. So maybe to pick both of those apart a little bit more, on the former, I think it's very safe to say, and I can say this as one myself, right? Psychiatry as a specialty is probably the most backwards in all of medicine when it comes to the adoption of new technology and the adoption of new process. I think psychiatry is the only specialty where if you did a survey today, you would find some significant portion of psychiatrists in this country, 10, 20, 30%, who still use paper charts. I don't think you would find 5% of doctors in any other specialty who are on paper charts, right? I think we are a field that has been very skeptical about the use of data and analytics and information in the way that we take care of our patients. Now, that hasn't happened, totally without precedent, right? There have been many instances of kind of misuse, of kind of minimization and marginalization of Americans who are suffering from mental health conditions. And as a specialty, we've typically had to be the folks who are protecting those patients. So there's always been some skepticism, right, around the way we interact with the larger health system. However, I think in the last 10, 15, 20 years, a lot of that cultural narrative has shifted. There's a lot more acceptance and a lot less stigma around the work that we do and the suffering of our patients. And I think it's time for our specialty to recognize that and to come along. We made a lot of progress in the last 12 or 18 months there, right? As a field, I think behavioral health is one of the most rapidly evolving specialties in medicine. It's where you've seen some of the most fast-paced innovation when it comes to technology and platforms that can serve to both turbocharge the clinical workflow and experience and also to smooth out the patient experience. So I personally believe the incorporation of new technologies and use ambient scribes as one of the most basic is now table stakes in our field. I personally believe by the end of this year, and a care delivery organization in mental health that doesn't have an ambient scribe is behind the curve. And that's going to become a baseline expectation of a therapist or a psychiatrist looking for a corporation or organization to join. So that's the former. And then on the latter, that also ties to this idea of we're not treating an organ, in our case, the brain, in isolation from the rest of the body. Again, historically, we've had to operate separately because we didn't always have the same trust or buy-in from colleagues on the other side. That's changed. And I think today it's very widely accepted, right, that the work that we do and the diseases that we treat, they directly impact the diseases our colleagues treat, right? Our colleagues now know they can't manage their patients' hypertension or type 2 diabetes or CKD without also making sure the comorbid panic disorder or anxiety or depression is treated. So we've made strides when it comes to kind of the medical institution's understanding and acceptance. Now it's our job and the onus is on us to actually integrate with the healthcare ecosystem and to deliver, again, that idea of truly integrated care so that we're coordinating closely with our peers who are managing other organs, and we're truly delivering kind of whole patient and whole body health.
Excellent. Amit, how about you? What's the direction psychiatry needs to go?
Yeah, I would echo a lot of what Arpan said. I think we have very similar thoughts on this as we've written about this too. We co-write together. But I think what I can add is kind of touch a little more specifically on this idea of measuring things, right? And so in the rest of medicine, we measure everything, right? You measure your blood pressure, you measure your cholesterol level, you measure or you take a picture, an X-ray to figure out what's going on with your bone and you're looking at it, right? And so in psychiatry and in behavioral health, we historically didn't measure things as much as we should, right? And there was some skepticism against measuring and the use of measurement-based care. That is quickly changing, rightly so, right? Over the last decade, there are validated measures and tools that we can and should use on a consistent basis to track outcomes for patients, to really make sure that we know we know what the end is, we know what the finish line is, right? Things like therapy aren't designed to be lifelong, ideally, right? Like therapy is a targeted treatment tool that should be used with a goal in mind. And once that goal is reached, you're saying, is there anything else that we are working towards? And if not, discharging from care. And so it's about doing that consistently, and sometimes building that muscle, doing those things, measuring towards outcomes comes with that skepticism, but I'm happy to say that it's shifting very rapidly. And I think we have to keep championing that shift and saying those measurement tools we use aren't perfect, but no tool is perfect. So you use it as a part of the data points of that patient to say, okay, this is what the tool is showing. Now, what are you telling me? And then you marry those together to come up with what you think is going on. And sometimes the tool might be a little off because it's a tool, which is not perfect. And that's why a human is part of that component of it. And that's what we're doing with the clinical judgment. Just like a primary care doctor who may see a high blood pressure may think about it differently based on the context of what the patient is telling them, right? And so it's the same way we use our tools, that we have to keep using that nuance and keep pushing that forward. And at the end of the day, that's also how we then prove that the care we're delivering is actually improving patients to the people in the ecosystem who want to know that, which is our payer partners, right? They're the ones who want to know that, hey, you're saying this is working, but show me.
Yeah. And if I can add one thing, as a specialty, I would argue that we have maybe over-rotated and over-corrected on this point, actually, to the point of over-indexing, to Amit's point, on the PHQ-9 and the GAD-7 to call out 2 scales as being the end-all be-all. And I think me and Amit have certainly led this movement of measurement should inform care, but it shouldn't be the only data point that's used in understanding the care of a patient. Something a lot of my colleagues have heard me say is, like, patients don't really care about their standardized scale score, right? I certainly have never had a patient come into my office and sit in the chair and say, doc, my PHQ-9 score is way too high. Can you help me get it down, right? Patients care about, I'm so depressed, doc, that I can't get out of bed and go to my kids' football games on Friday nights, right? So our job is to understand the patient's goals and how are they making progress against that, to Amit's point. And yes, the measurements and the tools and the scales are one piece of that. But as an industry, we have a lot of thinking to do. And I think we need to work towards starting to build these frameworks of, like, what are the tools and measures that we should be indexing on? And I think we both feel strongly that these clinical scales are one piece of the puzzle, but they can't be what, clinicians, care delivery organizations, or payers put all of their attention and focus on.
Yeah, I think that's where really, like, one of the things that really drives that for us is because we serve a Medicaid population, there's a lot of emphasis on treatment planning, which is not an emphasis in other like commercial insurances will not mandate those types of things typically. And so it's kind of saying we must have a goal we're getting to. And that goal, like Arpan is saying, is a mixture of using the tools and then your understanding of what's going on with the patient to get there and proving that you're getting there, to then say, we've successfully completed treatment for this person, and being able to identify what success is. And yeah, it's something that, like, there's no consensus on today. What is success? And every person has their own definition, every org, every payer, and it's messy because everyone thinks about it differently. And, I'll be talking to one group and they'll say, hey, we want to know about this measure and this scale. And then someone else is going to say, no, we actually care about this other one. And then we're sitting here like, okay, well, I can't do them all. So which ones are we going to pick and have faith and belief in as a company? And then as a field is where we really need to get to Arpan's point.
Oh, such great points. I mean, the measurement piece, as you said, Arpan is transforming our space, and alluding to what you said earlier, it's allowing the behavioral health teams to get the credit for so much impact they're making in all of the patient's health. But yes, got to balance the qualitative and quantitative feedback and all kinds of sources. Just really helpful. Love that. If I could double down just on one little piece, everything that you both are saying is going to require a culture change, especially for the providers that have been practicing for years. As maybe neither of your practices, do you have any advice for how you've coached clinical teams to make that transition to embrace measurement a little more?
Yeah, I can go. And I know Amit has done a lot of work here, and he's kind of one of our field experts. So want to hear his thoughts too. Couple of thoughts. One is, again, I'll say something that's similar to what I said earlier, which is, as clinicians, I would argue that mental health clinicians are the most intellectually inflexible and rigid across all specialties in some ways. So what that means is, as a clinician myself, managing folks like myself is not always the easiest thing to do. And again, there's reasons for that, but it is something that needs to change over time. A couple of things I've found to be very successful here. Number one is again, to Amit's point, there's mistrust around the use and the outcome of what's going to happen when we started using these new technologies or new tools. And I can tell you one of the most frequent questions I get is, so are you going to use the PHQ-9 score of my patients as a scorecard of my effectiveness as a therapist or as a psychiatrist? And I think it's our job to, again, dispel this idea that that single number is the end all be all that dictates whether a clinician is good or not at their job in its most basic format, right? And I think secondly, it's about helping clinicians understand why this is critical to the work they do. And I commonly use this example of, as you said, Solomay, historically, we haven't gotten credit for the impact we have on our patients' health and on our patients' lives. And this, using measurement-informed care, is one way we can actually start to quantify the impact we're having and ultimately the impact we're having on the patient's whole health. And that moves us forward as a field. It gives us more say in the treatment plans and the care of our patients. It also lets us advocate for ourselves when it comes to, working with employers and payers to get the right payment and the right structure, compensation for the work that we do. And ultimately, it continues to break down the barriers and stigmas that exist that have siloed us as a specialty. So those are a couple of my nuggets, but I'm curious to hear your thoughts.
Yeah, I think, it's similar to what you said. It's about teaching and making sure that the clinicians understand the use of these tools, how we're using them, and that they're just data points in a broader picture of what's going on, right? And there's a study that was done now a number of years ago that showed the majority of, it was psychiatrists and psychologists in the US that were polled on this, is that the majority of psychiatrists and psychologists thought that they were in the top quartile of their field. Now, that's an interesting statistic. What piques my curiosity on that is what that's telling me, though, is that maybe we're not as good at understanding if the treatments we're delivering are effective, right? And so in other fields, there are really standardized ways to figure that out, right? But in our field, it's just been historically harder to know that. And I think it's instilling that idea of we're lifelong learners. And so identifying something that maybe you are lagging behind your peers is actually really important. And it's not something that you can't fix, right? We can level people up. We can do more training. There's so many great resources out there to expand your knowledge base, but you want to know where those deficits are. And so tools like this, looking at population health, can help you understand maybe there are pockets where I can learn more so I can help my patients even get better faster. And so I think it's about having that lifelong learning approach to care. And because care changes over time, right? And so if you're not constantly staying up to date, if you're not constantly reviewing new literature, you're going to fall behind. And you have to be able to have some signal to show you that sometimes, to say, maybe I need to go spend some time brushing up on my autism spectrum disorder treatments, because I think maybe some new things have come out and maybe new approaches to care that I really want to know about that, I just haven't done yet.
There's also something to be said about kind of organizational design that helps drive this. And I think this is something that's both Soul and Brave have, at the core of their DNA, right? The way we approach the employee value proposition, the clinician value proposition, right? And this idea of kind of intellectual curiosity and flexibility and this value of lifelong learning being critical in the types of clinicians who we want to join our team and we want to attract to our team, because we invest a lot in doing that education, that support, that mentoring, and having that as a core tenet of who we look for, right, when we're looking for folks to join our team, and also in the way we want our clinicians to really be bought into our care model, makes a really big difference here, right? If a therapist is working on a couple of different platforms, kind of seeing patients coming to them from 3 different inbound sources, and then also has a private practice, and then also sees patients in the hospital on the weekend, it's really hard to keep things straight, right? And I've been there myself, working 2 or 3 clinical jobs. So I know at Soul and certainly I know at Brave too, right? This emphasis on clinicians who are kind of bought in and they want this to be their primary or only clinical responsibility, lets them fully devote all of their attention and all of their intellectual curiosity towards what we're doing and help us coach them in that way.
100% agree. Huge. And here at Brave, we're also very upfront with the populations that we treat. And we tell clinicians when we hire them, come join us if you want to work with complex patients, with patients who have high acuity, multiple comorbidities. That's what we do. That's the people we look for. If that's exciting to you, come join. But for some people, that's like, hey, like that's not what I want to do. And that's totally fine, right? And so that's why we want to be as upfront as possible when we're talking to potential new clinicians about the type of care we deliver and how we think about us as kind of the way we describe it as the safety net to the safety net.
It's so great. And Amit, thinking about what you said earlier, I'm from Minnesota, so definitely familiar with the Lake Wobegon effect, but knowledge is power, and there's more tools than ever today to support and upskill clinicians to quickly embrace the changing times. And you both have offered such great insights into running successful clinical organizations. I would love to just ask you each one more question if I could. Maybe Amit, I'll start with you. What advice would you offer a new psychiatrist just entering the field of digital health in particular today?
Yeah. So what I would say is that trust your training. Your training has prepared you for quite a bit. And use your ability to be a lifelong learner, to be someone who can learn things quickly to your advantage. And that you're going to be in, like, as you join these types of companies, as you grow in leadership roles, you're going to be in conversations where you're learning new languages. Just like you had to learn a new language when you went from your pediatrics rotation to your surgery rotation, you have to learn whole new languages that they use. It's the same thing when you start to think about leadership and the business side of things or working with payers, right? Those aren't things that you get taught in medical school or in training, but it doesn't mean you can't learn it fast. And so learn the language, listen to what people are saying. Don't be afraid to ask questions. If someone says an acronym that you don't know what it means, it's fine to say, hey, like, what does that mean? Can you explain it to me? There's no expectation that we know everything from day one. And I think sometimes as doctors or as clinicians, our patients expect us to have all the right answers all the time. But when you're in this other mode, it's okay to not have those right answers, and don't feel afraid when you don't. Because I think when I first started, I had a feeling that I had to have that answer all the time. And I realized quickly that that was a detriment. And the more questions I asked, the more people would teach me and the more I was able to learn.
Arpan, how about you?
I would echo a lot of what Amit said. And maybe if I rewind a little bit, so before I think about clinicians who are coming out and wanting to become leaders, let's say in digital health or innovating in the mental health world, and this is particularly focused towards psychiatrists, I would say become a great psychiatrist, become a great clinician. I think the work that me and Amit do and the mile of success we've had in doing what we do is 100% rooted in the fact that I believe we both deliver great care to our patients and have a very deep understanding of the science of what we do. And like we mentioned at the top, Solomon, I don't think any of this works unless the clinical foundation, the clinical rigor is there, right? No business model is going to make up for taking poor care of patients. So that is 100% the core of what we do. So focus early on your career on becoming the best clinician, the best physician, the best psychiatrist you can, and everything else will follow, as I said earlier. And I think related to that, and this is related to some work me and Amit are doing, we're going to be teaching a course starting this fall at UCLA for the psychiatry residents, is as a clinician in training, whether you're a psychiatrist or a psychologist, push your program, push your residency program, push your postdoc, and ask them, how are you going to teach me to be a great leader? Now, I need to understand the basics, that how to diagnose and treat psychiatric illness in the case of a psychiatrist, but in 2025, I can't be a great physician unless I also understand how the system works. So I think the onus is on trainees to push their hospitals, push their program directors to provide them with the resources and the knowledge and the learning to actually be effective physicians. We know today, right, the American healthcare system is complex, and that's an understatement. And one cannot be an effective physician unless they understand the challenges that a patient face. And me and Amit have learned that I didn't learn any of that when I was a resident. I learned that trial by fire in the last 5-10 years. And as a country, we should be prepping our physicians, our young physicians, to do this straight out of the gate. So I think that's a call to action for everyone who trains future clinicians and future physicians to think about how you're preparing your trainees to be effective physicians, effective psychiatrists, effective clinicians in the healthcare system that we all have to navigate and work in today.
Just so wonderfully said. I thank you both for just sharing your experience and the incredible insights in today's episode. And for our audience, if you like what you heard today with Drs. Amit and Arpan Parikh, you'll want to be at the 2025 Behavioral Health Tech Conference. Again, we're the largest community focused on expanding access to mental health, addiction, neurodiversity through technology, health equity, and innovation. And if you like what you heard here, we're going to have tons more conversations with experts like Drs. Parikh. And so super excited to see you both again this fall in between your big jobs and apparently teaching this residency program as well. But so appreciate you taking the time with us today. Thanks again.
Thanks for having us, and see you in San Diego in a few months.
Yeah, excited for it. Mm-hmm.